Welcome everyone. Today we're going to do a very light review of chemotherapy, and this will probably take 4 sessions to go over, and so look for that in the schedule in the upcoming weeks. I'm ChicagoDLSinc. I do one-on-one tutoring for the Naplex and the MPJE, and do group sessions as well. Shout out to Suspicious Bunch and Pharma Turtles for arranging this. And my resources are RxPrep and Past Naplex Now. Both are excellent resources. Pick one and stick to it. Everyone learns a little differently. If you're doing practice questions and feel like something is missing, then supplement that with external resources. There's an excellent official guide for PharmaPrep. Definitely look into that. Hold all your questions until the end. I'll be happy to answer any of them having to do with a session or having to do with the Naplex or the MPJE in general. We will go ahead and get started with the cell cycle. There's going to be 3 slides. They're all going to have 3 different graphics. However, they are all the same. So 4 cell cycles or 4 phases in the cell cycle. We have M, we have G1, we have S, and we have G2. M phase is where the cell undergoes mitosis. If you recall, that is cell division. The vinca alkaloids and the taxanes are the medications that act there in that cell cycle, in that phase. The G1 or the GO phase is where the cell makes the enzymes necessary for DNA synthesis. So alkylating agents and anti-tumor antibiotics work here and on all phases. S phase is where the actual synthesis or replication of DNA occurs. So here we're going to have antimetabolites such as methotrexate. The G2 phase, we have RNA and other proteins are synthesized during this phase to prepare for cell division during the M phase. The plant alkaloids etoposide, teniposide, and irinotecan work there. All right, continuing with the cell cycle, we have the M phase. The taxanes are going to be paclitaxel, brand name is Taxol, and docetaxel or Taxotere. On the right, you'll see another graphic. This one has different colors labeling the different parts of the cell cycle. And for S phase, 5-fluorouracil, Zolota, and 6-MP also act in the S phase. And then in the G2 phase, we talked about the plant alkaloids. So the cell cycle specific drugs work during a specific phase. This is effective for high growth fraction malignancies. Now, most cancers, as we know, have unchecked metabolism and unchecked growth. And so what we're trying to do is provide a check using certain chemotherapies. So the antimetabolites like methotrexate, they interfere with the normal synthesis of nucleic acid in the S phase. And in the M phase, we count on the plant alkaloids. So the non-specific drugs work during any phase of the cell cycle, and these are effective for solid tumors and that we consider low growth fraction as well as high growth fraction. Alkylating agents are cytotoxic, which means they are cell killers. You've probably heard or experienced or mentioned that chemotherapy not only takes care of the bad cells, but also the good cells or the normal cells of the body. That is the meaning of cytotoxic. So, some adverse effects, nausea and vomiting, bone marrow suppression, and the signs will be neutropenia, thrombocytopenia, and anemia. In addition, tumor lysis syndrome, there's a graphic to the right. There will be metabolic and electrolyte abnormalities and chemotherapy-induced peripheral neuropathy. Now, all of these are very high yield for the Naplex, so make sure when you're doing your review that you take your time. So, let's talk about some antiemetic medications. On the top right, you'll see Emend is the brand name, and the generic is going to be aprepitant. And starting at the top, we have 5-HT3 serotonin receptor blockers. Dolacitron, granisetron, ondansetron, and polonacitron. Brand names are going to be Anzimet, Kytril, Zofran, and Aloxi. Steroids, we use dexamethasone. Brand name is going to be, actually in the chat, can anyone tell me the brand name for dexamethasone? Please type that into the chat. NK1 receptor antagonists are going to be aprepitant, fosaprepitant, rolapitant. And then number 4, we have cannabinoids. So that's going to be dronabinol and nabilone. Dopaminergic antagonists such as metoclopramide, brand name Reglan. We have antihistamines and benzos as well. Patients on cisplatin or other highly emetogenic agents can add olanzapine, which is off-label, on days 1 through 4 to standard therapy. So in addition to the 5-HT3 receptor antagonist, dexamethasone, and the NK1 antagonist. So Decadron is correct. I will accept Dexpac. And Soma, there is no need to yell. We are with you. It is Decadron. Great job, everyone who wrote that down. Brands and generics are very important. There are the top 200 as well as the top 300. And the links for those are in the guide. Please make sure that you review those in preparation for your Naplex. It is very important. It used to be 200. Now I always recommend 300. You don't have to do them all in one day. Do 10, 20, 30 a day, and before you know it, you have 300 in your brain. So, the treatment, there's usually 3 agents for chemotherapy-induced nausea and vomiting, and if need be, you can add olanzapine to make it 4. All right, very good. Next, we have on the top right, you see Kytril or granisetron as a 1 mg, 1 mil solution for injection. So Anzimet is available IV and PO 100 milligrams and PO single dose 1 hour prior to treatment. IV administration is no longer indicated because of risk for QT prolongation. Can anyone in the chat tell me any other medications that have a side effect or adverse effect for QT prolongation? In the chat. And if you don't know, that's okay. Please make a note and go back and review it. Here is the time for you to identify gaps in your knowledge base. And if you're not sure, review it. So when you take the Naplex, you are prepared. All right. So while those answers come in, granisetron is available IV, PO, sub-Q, and transdermal patch. IV Kytril, 1 milligrams 30 minutes prior to treatment. Orally, 1 mg once a day or twice a day, 1 hour prior to treatment. The extended release sub-Q brand name is Sustol. 10 milligrams sub-Q 30 minutes prior to treatment for 7 days or every 7 days, excuse me. And transdermal patch brand name is Sancuso. one patch 24 to 48 hours before chemo for up to 77 days, and avoid the sun. If you answered SSRIs, Passerone, fluoroquinolones, or macrolides, you are correct. Great job. Great job. All right. A couple other ones are probably going to be antifungals and Allegra, aka fexofenadine for allergies. So, top right graphic, we have polonistron injection, and it's 0.05 mg per mil. And the dosages here, Zooplens is going to be the thin strips that melt on the tongue. IV dose no more than 16 mgs due to QT prolongation. Uh, the 5-HT3 inhibitors have long half-lives. Polonocitron has 36 to 48 hours. It is going to be a 0.25 mg IV 30 minutes prior to chemo. Combos are going to be nitupetant plus polonocitron, which is a Kinzio, and you do it orally 1 hour prior. And you can also do it IV 30 minutes before chemo on day 1. All right, next we have the steroids. So Decadron, aka dexamethasone, it's used alone or with 5-HT3 antagonists. They have an additive effect, so the efficacy is improved. For prophylaxis, we do 8 to 12 mgs IV or PO 1 hour prior to chemo in combination with a 5-HT3 antagonist and the NK1 antagonist. Medrol or methylprednisolone can also be used. Common side effects include upset stomach, anxiety, insomnia, and hyperglycemia if used for several days. Caution for patients with diabetes. Now, next we have the neurokinin 1 receptor antagonist, also known as the NK1. And on the top right, you see Verubi, the mechanism of action. On the bottom right, you'll see a vial and the tablets. So a prepitent is emend, that's oral, 1 hour prior to chemo, and we combo it with 5-HT3 antagonists on day 1 and dexamethasone days 1 through 4. It is a 3A4 substrate and inhibitor and a CYP2C9 inducer. So, fosaprepitant is the prodrug of aprepitant 30 minutes prior to chemotherapy on day 1 only. Verubi is going to be IV or oral, and if you're going to do oral dosing 1 to 2 hours before chemo on day 1 only, it has a very long half-life, lasts up to 7 days. It is a 2D6 inhibitor. If a patient has a legume or soy allergy, monitor for hypersensitivity, and it blocks substance P, which activates a pathway in the brain that causes nausea and vomiting. All right, very good. Next, we have cannabinoids. So, dronabinol is Schedule 3, and Marinol is the capsule, and Syndrose is the oral solution. It is refrigerated. 1 to 3 hours prior to chemo is when you administer it, and then 2 to 4 hours after chemo for a total of 4 to 6 doses in a day. Marinol is also approved for appetite stimulation in AIDS patients. Administer BID before lunch and dinner. Now, I don't know if you knew this. Chemo can destroy or cause damage to the center in your brain that causes hunger. So, in order to prevent chemotherapy induced cachexia, and I'll type that into the chat, or wasting syndrome, marijuana or cannabinoids are used to stimulate hunger in patients undergoing chemo and post chemo as well. That is the exact mechanism of action. So, nabilone is Schedule 2. It's BID, but does not have to be refrigerated. All right, top right, you'll see Reglan. You'll see the tablets and the different injectables. It is a dopaminergic antagonist, metoclopramide or Reglan. It's available orally, IV, and IM. It blocks dopamine in the brain vomiting center. At high doses, it can affect 5-HT in the stomach, and it helps move food out of the stomach more quickly, reducing nausea. Side effects are going to be diarrhea, CNS symptoms are quite prominent. Benadryl can help ease some of the side effects. Prochlorperazine are PO or per oral tablets, and there is a brand named Compro, which is a rectal suppository. Make sure when you are dispensing any rectal suppositories that you go over it with a patient. Sometimes they will not know to remove the aluminum wrapping or plastic wrapping. Now, antihistamines commonly used. Here it says not very effective. I think it's very effective as an adjunct. Diphenhydramine, aka Benadryl, is available orally, IVIM. Hydroxyzine, brand names are going to be Vistaril and Atarax, is available IM. For chemotherapy induced nausea and vomiting. And the side effects are going to be relaxation, drowsiness, dry mouth, and constipation, which all are anticholinergic. Last but not least, we have benzos. So lorazepam, which is a brand name of Ativan, we dose at 0.5 to 1 mg orally every 6 to 8 hours. And it can be used off-label for breakthrough nausea and vomiting or as an adjunct. It is an anxiolytic with some anti-nausea effect. It works by calming the brain. Here it says not very effective. I would say anecdotally it is effective if it comes to it. Um, and if given for nausea and vomiting, we combine it with the other 5-HT3 inhibitors and corticosteroids. All right. So I have 5 practice questions. For those of you that are new, what I will do is I will read the practice question, and when I'm done reading it, type your answer into the chat. If you're not sure, feel free to put a question mark by your answer choice. That signifies that you are guessing, or just guess. There is no points all for the wrong answer, and here there are no points at all. Once again, if you are not sure about the topic or the questions being asked, whatever stage you are in your prep, make a note of it, review it after this session or tomorrow, and that will help with retention. All right. Which of the following chemotherapeutic agents has a maximum lifetime cumulative dose due to cardiotoxicity? Choice A, doxorubicin. Choice B, paclitaxel. Choice C, vinblastine. And choice D, bleomycin. All right. So everyone so far has chosen A, and A is the correct answer. Let's talk about why. Anthracyclines have a recommended lifetime cumulative dose due to cardiotoxicity. The lifetime dose limit of 550 mg per meter squared is the limit, and I think 450 is where we try to keep it. So 450 mgs per meter squared, and 550 is the lifetime dose limit. If you answered A, good job. Now let's go on to practice question 2. Which of the following severe toxicity concerns is included in the boxed warning for bleomycin? Choice A, cardiotoxicity. Choice B, ototoxicity. Choice C, pulmonary. And choice D, hepatotoxicity. All right, very good. It looks like we have a consensus, and the answer is C for chemotherapy. Pulmonary fibrosis is a severe toxicity included in the boxed warning. This is usually not tested, but for your knowledge, there is a lifetime cumulative dose limit for bleomycin of 400 units. All right, great job so far. Now, these are a little easier questions, and as we get through chemo 2, chemo 3, and possibly chemo 4, the questions will get a little more difficult. So, which of the following is a notable safety concern commonly associated with taxanes? Choice A, hemorrhagic cystitis. Choice B, loss of hearing. Choice C, acute kidney failure. Choice D, peripheral neuropathy. All right. So the answer choice here is going to be D. Peripheral neuropathy is a well-known safety concern associated with taxanes. A does occur with others, as does B and as does C. However, peripheral neuropathy is going to be our main focus with taxanes. All right, good job so far. Practice question 4. Ifosfamide, a chemotherapy agent, is always given with mesna. What is the purpose of mesna when given as an adjunct to ifosfamide? Choice A acts as a pharmacokinetic booster. Choice B acts downstream to increase efficacy. Choice C reduces the risk of myelosuppression. Choice D reduces the risk of hemorrhagic cystitis. All right. D is the correct answer. It reduces the risk of hemorrhagic cystitis. So, uh, both cyclophosphamide and ifosfamide have a toxic metabolite called acrolein, and mesna binds with that toxic metabolite and reduces the risk of hemorrhagic cystitis. You're also supposed to hydrate the patient or counsel the patient to hydrate to reduce the risk of hemorrhagic cystitis. All right, even if you guessed, great job. All right, last but not least, Which characteristic side effect is included in the boxed warning for irinotecan? Irinotecan. Irinotecan. All right, looks like there's a consensus here for diarrhea, and that is correct. It is very characteristic. Early onset diarrhea may be treated with atropine, and late onset may be treated with loperamide. If it is so severe, sometimes we have to consider the benefits and the risks, may have to change the chemotherapy agent. All right, very good. Does anyone have any questions or concerns for today? Happy to answer any questions about the lesson, any questions about the Naplex, and any questions about the MPJE.